All right, so welcome once again to the next session. We are looking at the first week of embryogenesis, and this will include cleavage, blastocyst formation, implantation. So we just finished looking at gametogenesis, where the male and female gametes were formed. Now, when there is fertilization, you have a zygote formed. And once the zygote is formed, it keeps developing. So that's what we want to look at now. So assuming this is the egg and then the sperms are trying to enter, eventually one will be successful. The two pronuclei will fuse and form a zygote. Then the zygote will undergo a special form of division known as cleavage. Once it is divided into two, you have the two-cell blastula. Then each of the two-cell blastula will also undergo cleavage to give 4. And the 4 will continue to give 8, and so on and so forth. So at a point, you have what we call the morula. Then a cavity starts appearing within the blastomeres. We call these single cells the blastomeres, okay, those that resulted out of cleavage. So the spaces coalesce or join to become a bigger space. Once that happens, the space will push the rest of the blastomeres to the top, or what I usually call the North Pole. Once that happens, the space is given the name the blastocyst cavity. Okay, and then the cells, the blastomeres that were pushed to the North Pole will become the embryoblast or the inner cell mass. So now the inner cell mass or the embryoblast, together with the blastocyst and the rest of the blastomeres that did not form part of the inner cell mass or embryoblast, will become the trophoblast. So that is the trophoblast. So the trophoblast together with the blastocyst cavity and then the inner cell mass will be called the blastocyst. Okay, we call the blastocyst. The zona pellucida at this point is still there and disintegrating bit by bit. So eventually it will be no more. You only have the trophoblast. Now, it is expected that by the 7th day after fertilization, between the 6th and 7th, you should have implantation occurring. It means that the blastocyst should have traveled and made its way towards the endometrium. Okay, so that is what is happening. So by the 7th day, then implantation has already started. Now, once the blastocyst gets in touch with the endometrial lining of the uterus, the trophoblast will start differentiating into a syncytiothrophoblastic and then a cytotrophoblast. The difference between the two is that the cytotrophoblast has individual cells within their own cell membrane. So you can actually count the individual cells. Here you can count 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Okay, cytotrophoblastic cells. Then the syncytiothrophoblasts are termed multinucleated because they don't have the individual cell membrane surrounding them. Okay, they have just one cell membrane with several nuclei within them. So they are known as multinucleated cells. And that is what eats into the endometrial lining, okay, and helps the conceptus to implant in the endometrium. And we will come to realize that it's the same syncytiothrophoblastic that will help in the formation of the placenta. So this is a description of what I have explained. You started having cleavage and then cells resulting from that cleavage known as blastomeres. Then a space appears within the blastomeres, they coalesce and then push the rest of the blastomeres to the top or North Pole. Some of the blastomeres remain circumferential. They do not move, and they will become the trophoblastic cells. Then the ones that move to the top will become the inner cell mass or embryoblast. You can see disappearing zona pellucida, as I said earlier on, and that is the trophoblast. So a summary again: 2-cell stage, 4-cell stage, 8-cell stage, morula, and then you have the blastocyst cavity, trophoblast, inner cell mass. Okay, so that is a 3D cartoon of what I am explaining. Okay, so again, as I always do, I keep explaining the same thing over and over again so that it will sink. We have blastocyst cavity, and that blastocyst cavity can now be called blastocele. So that's another name for the blastocyst cavity, blastocele. That is the inner cell mass, and that is the trophoblast. So this is an unfertilized egg. When 72 hours after fertilization, you have all these blastomeres formed. Then you have the blastocyst. So you can see how the blastocyst tries to implant with the syncytiothrophoblastic forming and eating into the endometrium. So this is the endometrial lining. Okay, that's a simple columnar epithelium on the lining. So implantation goes on. So that is the blastocyst. It gets attached to the endometrial lining, and then it starts invading the endometrium, and then eventually to enter the endometrium, and that will actually complete the implantation. Okay, so once again, you have the process in another cartoon. That's the endometrium. Then you have the eating into the endometrium by the syncytiothrophoblastic, primitive cytotrophoblastic cells, primitive syncytium. Then you have the bilaminar forming, which will be in the second week. Okay, that will give us epiblast and then hypoblast. So we will dwell more on that. This lacunae will collect blood vessels and then start forming the placenta. So you can see that blood has collected. So you now have the lacunae with maternal blood there, and then the fetal blood will also be forming. So if you have something like this and you're asked to label, I think that should be very, very, very easy. So we start with 1, that will be the blastocyst cavity. 2 will be the trophoblast. 3 will be zona pellucida, and then 4 will be what? Inner cell mass or embryoblast. Okay, so that is the same thing going on. A similar thing also going on. Then the syncytiothrophoblasts has started forming. So now you can see that the blue region we call the embryoblast or inner cell mass has now gotten a new friend in yellow beneath it. So that is the hypoblast or primary endoderm. Primary endoderm. And you still have the cytotrophoblast there and then syncytiotrophoblaст. So what has now appeared is the hypoblast. And this usually occurs in the second week. So there are a few terms I want you to consider: totipotent cells, pluripotent cells. And the totipotent cells are capable of forming a complete embryo. So any of the blastomeres can be taken out and put in a medium, and then it will grow and become an embryo, full embryo. So we call that a totipotent cell. Then pluripotent cells are capable of forming any tissue. So they are usually what we call them as mesenchymal cells, okay, or stem cells. So they are pluripotent. Twinning is something I have already covered fully in one of the videos. So I will go through quickly to lay a foundation. You have either dizygotic twinning, monozygotic twinning, or the conjoint twinning. Now, for the dizygotic, which we usually call the fraternal twins, they come from two separate eggs and then two separate sperms. And so their sexes usually are different. And then also they have different, genetic makeup because of the different types of eggs and then the sperm that produce them. They also share different placenta and then different chorionic membranes as well as different amniotic membranes. Now, when you come to the monozygotic twins, it's a single egg fertilized by a single sperm. Then at the point where the blastomeres are being formed, they separate. Okay, some of the cells move to the right, some move to the left, and then there's a space. Now, I want you to bear in mind that all these things we are talking about in simple terms are governed by molecular signals. Okay, as whether cells will even move and at what rate should they move. Okay, all are governed by molecular signals, which we are not covering at this level. That is why when there's a mistake or mutation, you end up having the third type of twinning, which is the conjoint twin. It means that the separation was not complete. Okay, so that is what monozygotic, dizygotic, and then conjoint twins are. So this is another diagram that also explains it further. So for the dizygotic, you have two separate eggs, two different sperms, and then two individual, morally developing, two implantation occurring. So you have dichorionic, diamniotic. When it comes to the monozygotic, we even go further to give different types of monozygotic twins, depending on how early or late the splitting occurs. So at this point, you have morular splitting, which is quite early, and then you end up having two blastocysts, and then the blastocyst will implant, and then you have different chorionic, different amniotic cavities. All right, similar to that of the dizygotic twin, but remember this is a monozygotic twin, so they are going to share similar genetic makeup. However, because the splitting occurred early, a lot of things are separated. Then when you get to this point where the splitting does not occur at the level of the morular stage, but rather at the level of the blastocyst stage, you end up having monochorionic, which means they will share one chorionic cavity and membrane, but they will have two different amniotic membranes. Then when you look at this very last one, you have the splitting occurring very late, okay, when actually it has started implanting on the endometrial lining. That is where the splitting, is almost complete. So you have different stages or different types of even the monozygotic twins. So this is another diagram that explains it further. As I said, I have already covered this in details online, so you can visit that site and then watch. Then we look at assisted reproductive technology, also known as ART. The basic steps in the ART, one of the commonest one is the IVF, is that you stimulate the ovaries to produce a lot of oocytes. Then you retrieve the eggs, and then you do fertilization in the lab. Then when the fertilization is successful, you can culture the embryo and then later transfer them, depending on what the patient wants. Okay. You can also cryopreserve the eggs for future use. So this is a diagram that is indicating how the process occurs. So hormonal stimulation, which means that you give synthetic analogs of the natural hormones that help in ovulation, usually the luteinizing types of hormones. Okay, so a very common example is the clomiphene citrate. So that will cause multiple ovulation. Then you collect the oocyte from the follicles with an aspirator during laparoscopy, put it in a medium of a resemblance to the natural medium in the female, okay, and then put in capacitated sperms. Then you start observing the fertilization and cleavage that goes on. Then when cleavage is successful, you can decide to transfer some of these embryos or zygotes into the appropriate place. So if it's a zygote, then you put it in the fallopian tube. If it's an embryo, you put it in the uterus. So you have these types of assisted reproductive technologies. So this is the gamete intrafallopian transfer. That one, you put the gamete in the fallopian tube. So the male gamete will be there and then to fertilize. Then you have zygote intrafallopian transfer. That one, obviously, fertilization would have occurred outside the female body. Then you have the almighty in vitro fertilization too. Then you have the frozen embryo transfer and then intracytoplasmic sperm injection. All right. This has also been covered in details. So if you miss anything or you want to relax and listen very well, you can download the video and listen. So these are some of the medications, as I mentioned earlier. I mentioned clomiphene citrate, I mentioned luteinizing hormone analogs, among others. Then you can also give some medications to prevent premature ovulation. Okay, so you have some agonists and antagonists. All this is just a hormonal game. Okay, so either the hormone that will trigger or the hormone that will prevent. You can decide which one per the need. Okay. You can also do pre-implantation genetic diagnosis to see whether the genetic makeup of whichever component you want to use is clean, in quotes. So you screen, okay, for diseases. And in some labs, they can do that. Okay. So how many embryos would you want to be transferred? All would depend on the one going to bear the child and then those who are going to take care of the children. So each embryo has a fair probability of implantation development, and the number of embryos to be transferred should be determined for each patient, taking into account the challenges of the risk of multiple gestation. Are you sure you can carry as many as 8 to 16 pregnancies? Because you want children, you have to be careful what you can accommodate. Because one of the disadvantages of this ART is that because you can't tell the success rate, sometimes you end up putting in more than required. Okay, and then all of them can also become successful and you have multiple pregnancies. So maybe you wanted to just get one baby and then yet they put in 4. Okay, to see that at least if some of them do not survive or become successful, you get 1 or 2. Then maybe all the 4 will become successful. Okay, so the financial strength of the couple should be considered, and then the maximum number of embryos transfers transferred is based on the patient's age as well, and then the patient and embryo characteristics. So if you have
Hello,
extra,
Doc.
yeah.
Doc, please, with the IVF, after the external fertilization, is there a possibility that you can implant at least four and selectively terminate two or three after some time?
Okay, I mean, once even the usual pregnancies can be terminated, why not? This can also be done. But the fact is that you, the patient, are you ready to go through all those processes? Okay, and then it will also come with its, um financial responsibilities and all those surgical procedures and all that, medications. So sometimes you just have to, play it safer instead of allowing a lot of them and then later on trying to destroy them. You can as well go for that's the minimum number, at least maybe extra one to balance in case something goes wrong. Okay, but also some of the
Okay.
centers, yes, some of the centers are known for their success rate. So before you go to any center, you have to do your background checks to see whether this very center has a very high success rate. For that one, then you know that whatever number you choose, uh, your best bet will be that you get what you choose or select.
Okay.
Okay. Right. So if you have extra embryos, what do you do? So like you asked, somebody would decide that, oh, let me freeze some of my embryos, okay, for future use instead of putting most of them there and then later destroying. So you have what we call vitrification, okay, or the fast freezing. You also have the slow conventional freezing. All these things are possible. I'm not singing anybody's slogan. So screening of gametes or embryos, as I said, the pre-implantation genetic diagnosis can be beneficial to some couples. Okay, so I've already mentioned the gift, the zift. You can also have people to donate sperms, people to donate eggs, and even surrogacy or gestational carriers who will carry the baby if the woman does not have um, let's say a good womb, for want of a better word. So a womb that cannot carry a baby to term due to maybe hysterectomy has been done some time ago to maybe save the woman from dying. People do all sorts of surgeries for reasons best known to them. So if there's a woman who doesn't have the womb, then somebody can carry it and charge for that. Okay, so all these things are possibilities. Then also you may have mental professionals there to psych some of these patients up. Okay, so many ART programs have a mental health professional uh, or staff to help couples deal with grief, uh, tension, anxieties, okay, which are related to infertility. These things are very huge issues in marriages. But of course, if you are not uh, one who is facing these challenges, it will be far-fetched. You not even think about them. But when you are in need, you see that it gives a lot of you know unrest in marriages. I mean, you want to get married and get a baby on your own, something you can call your own, and then maybe all the toil you are having in this world, you want to leave it for something that came from your own body. And then you think of all this, the babies are not coming, and then, you know, it's psychologically very impactful. So, yeah. So you can estimate the age of the embryo before it even becomes a neonate or being born. Okay, so we call that the determination of gestational age. So embryo, conceptional age. You can use this method, menstrual history, the LMP, which is the last menstrual period. You can also use clinical examination by an expert. You can use also ultrasonography by a qualified radiologist. And the crown ramp length also can be measured from the head all the way to the caudal portion of the embryo to estimate. So the notable one is the menstrual history, which most ladies use. So for that one, once they miss their first period the following month and there's pregnancy, then they can count that maybe the pregnancy is 2 weeks old, 3 weeks old, 4 weeks old, etc. Do you see? So the contraceptive method that can be used, the barrier techniques, contraceptive pills, vasectomy, etc. There are so many of them. Other implants are there.
Hello, Doc.
Yes.
Doc, please, with regards to male infertility, so a situation where a male happens to have azoospermia, is it possible ART can help?
Azoospermia means you don't have sperms at all. So the only
Yes,
way
yes,
ART
they are
will
not
help,
able to produce.
yes. So the way ART will help will be the donation of what? A sperm. We said that somebody can donate a sperm. Okay, just as somebody can donate a uterus, not like it's taking the uterus out and giving it to you, but keeping your baby as a surrogate mother. Yes, people sell sperms. So if you want somebody's sperm to fertilize your wife's egg, that is your own decision to take.
Okay.
See. We also have ectopic pregnancy, and you have the tuber one and rectal uterine or the patch of Douglas one. This is usually caused by delay of the transport due to pelvic inflammatory diseases or endometriosis. We say delayed transport because, as I said today in the lecture, once there's fertilization by day 6, maximum 7, there should be implantation. The zygote should arrive at the uterus, okay, in the form of a blastocyst. If not, uh, it's going to be stuck wherever it is, and it's going to implant by day 7. The blastocyst doesn't know that it is in the fallopian tube. Wherever it finds itself by day 7, implantation will start. So you can see that in this diagram, you have a baby, an embryo developing within the fallopian tube. Okay, so that is what we call ectopic pregnancy. Sometimes it won't even happen in the fallopian tube. There are times that the ovaries are not attached directly to the fallopian tubes. There's a little space between the ovary and then the fallopian tube. So when there's ovulation, the egg is caught or absorbed like a magnet by the fimbriae or finger-like projections of the fallopian tube into the fallopian tube. Sometimes they will miss it, and then they will be floating within the peritoneal cavity. Okay, and so once that happens and there's a sperm, around that time, the sperm can go through the fallopian tube and then exit it and then locate that egg which is floating around and still fertilize it wherever it is. So sometimes fertilization occurs outside the fallopian tube, and then it also starts developing because it doesn't know where it is. So that one too, wherever it finds itself by the 7th day, it will start implanting. So if it finds itself on an intestine, it will start. Okay, and these structures are not meant for conception. Their muscles are not meant to hold a developing embryo. So eventually, it will rupture or cause severe bleeding. Okay, and we don't want that to happen.
Hello,
So,
Doc.
yes.
Doc, please, with the gamete intrafallopian tube transfer, I learned the target for the transport could be at the ampulla. But with the zygote into a fallopian tube transfer, is there a target around the fallopian tube such that after transport, you can guess that within 7 days from there, it should have reached the uterus for implantation?
Of course, these things are done by experts, so they also know this 6, 7 days thing we are talking about. So you don't go and put
Okay.
a zygote far away, where by the 7th day it won't reach the uterus. So the fallopian tube has parts, starting from the lateral to the medial. You have the fimbri, then you have the ampulla, okay? Then you have the isthmus, and then you have the intramural part. The intramural part is very close to the uterus. So you have to gauge and then determine the hours and days left for the transport, okay? People who are into this can actually calculate how many moves the zygote will make within what? A minute. So they can do all that and know exactly where to place it. That shouldn't be a problem at all. Thank you very much, and I hope this video helps. You meet some other time.